The premier event for infection prevention and control is coming to San Antonio this June. APIC's annual conference brings you the latest research, innovative products, and practical knowledge to help you prevent infection. From inspiring keynotes to thought-provoking panel discussions, APIC 24 curates an extraordinary platform for knowledge exchange. Meet IPs from around the world who face the same daily challenges as you. If you work in infection prevention and control, you don't want to miss this event. Learn more and register to join us in person or virtually at annual.apic.org.
You are listening to the 5-Second Rule podcast presented by APIC, the Association for Professionals in Infection Control and Epidemiology. This podcast is produced by the APIC Communications Committee and is intended to be a conversation between our hosts and professionals practicing in the infection prevention and control industry. You will learn and be entertained, but most of all, we hope you will be inspired by our community and the work of our peers. And now, on to the show.
Welcome to the 5-Second Rule podcast. We are your hosts. I am Lerenza Howard, and my preferred pronouns are she, her.
And I'm Kelly Holmes. My preferred pronouns are also she, her.
Today, we are joined by AC Burke. AC has been working with RB Health Partners Incorporated since 2016 and has over 25 years of experience working in public health and healthcare. She consults with long-term care facilities on infection prevention and control policies, procedures, and practices. AC provides trainings to nursing homes and at conferences, including the 17-hour nursing home infection prevention program known as NIP, where she helps to nip infections in the bud. Welcome to the show, AC.
Thank you. Thank you so much for having me. It's very exciting to be talking with you all today.
Thanks for joining us, AC. I really like that acronym, NIP in the bud. It's very catchy. So I think, a lot of times when we're talking about infection prevention, we all kind of, talk about acute care settings. And today I'm really excited to bring some more awareness to the post-acute world and, the long-term care settings. So I'm excited that you're here to talk to us about that today. But, considering your background, how did you get into the long-term care setting? What drew you to that?
So in terms of my background, I kind of had some different experiences in public health, acute care, long-term care. And over time, I just really realized that my passion was long-term care. I spent about 15 years in public health. And during that time, I had the opportunity to work for the Bureau of Epidemiology and work with some of those initial grant funds that we received through CDC to develop the beginnings of the Healthcare Associated Infection Prevention Program. As part of that program, I worked with acute care. I worked with long-term care. We had some various collaboratives and things that we did working with the facilities. And I just really found that I really enjoyed working with the long-term care facilities.
That's amazing, AC. So one of the things that I'm very curious about is the difference in the roles as an IP working in an acute care space versus a long-term care facility. Because of course, like many other individuals, watching the news at the height of COVID and just seeing some of the disparities that was experienced at long-term care facilities. So AC, share with us, how does the role differ as an IP between those spaces?
So in long-term care, certainly we have some similarities with acute care in terms of working with staff as it relates to hand hygiene, compliance with precautions, cleaning and disinfection, and things like that. But in terms of differences, so we don't have high-level disinfection or sterilization on site. However, we do have specialties coming into the facilities like podiatry, dermatology, dentistry, and certainly they have equipment that we need to keep an eye on. Also in terms of surveillance, so surveillance can be a little bit more personal in the long-term care setting. So oftentimes the infection preventionists, they'll know the resident as opposed to just a medical record of someone that we're reviewing and don't necessarily have a face connected with the name. And also, if that resident has family members that are active and in the facility, then there's also a good possibility that the infection preventionist will also know their family. So perspective can be a little bit different, and sometimes it might be a little bit more difficult to be objective when reviewing surveillance and trying to identify those infections. And then also from an organizational culture perspective, within the acute care setting, generally speaking, it's accepted that we need staff dedicated to infection prevention, and that infection prevention is indeed an expertise. And that's something we're still struggling with in the long-term care setting. So infection prevention isn't quite yet recognized as an area of expertise, and often people who fill this role, it's a little bit more of tag you're it, and they also often have other job responsibilities. So for example, in the nursing home, oftentimes the infection preventionist may also be the assistant director of nursing, or they may also be the staff development coordinator.
Yes. Yes, that makes it very difficult, I think, when one person is wearing multiple hats and you're responsible for a lot of different elements within the facility, because it does seem like, whatever fire is happening, the biggest fire at the moment, is where you need to direct your attention. And so then things like surveillance can certainly get, put on the back burner. And it's difficult to manage all of those roles at the same time. So, you were talking about how, it is a personal kind of connection, which is something that, I think is really important to understand, because this is where, instead of in an acute care setting where they're in and out in an average of 5 to 7 days, this is where these residents are living. This is their home. And so we do have to find that balance between keeping everybody safe and then quality of life. So that is, a very unique challenge that you bring to the table there. So, as far as the additional needs and resources that you see in this long-term care setting, what are some barriers that you can describe to us?
So kind of building on what we just talked about in terms of having multiple roles for the infection preventionist. So certainly anytime we're overwhelmed, just feeling like our plates are constantly overflowing, that can contribute to burnout. And just like with other healthcare settings, nursing homes and long-term care, they're also struggling with staffing, turnover. So certainly those challenges are there. But again, just making sure that the infection preventionist has the time that's needed in order to perform the job duties. And then also recognizing that infection prevention also requires ongoing learning. So if the infection preventionist is going to be successful, they need time for ongoing learning. And as part of that, many of the nursing homes and the leadership, they don't quite recognize the difference between being board certified, recognizing expertise, versus a certificate of completion for training. So the CMS regulation, so the Center for Medicare and Medicaid Services, CMS, so their regulation for nursing home indicates that they are to have an infection preventionist, and the infection preventionist is to have specialized training in infection control. Now, CDC has a free online course for this, and there's some other trainings that are also out there. And so many of the facilities, they'll actually have several people within the organization complete that training so that they can say that they're certified in infection control and say that they have staff certified in infection control. So it's still not quite yet recognized, and resources are needed to for infection preventionists to be given the time to further develop their knowledge and their skills and abilities as it relates to infection control. And then as part of that, also having some recognition for a certificate of completion for training versus board certification.
Yeah, that's interesting insights, AC. So from just out of curiosity, from your perspective, do you think that possibly pivoting the CMS requirements towards the CIC certification and or the more specifically the certification, board certification within long-term care facility, would that push the needle in really driving change from the conversion from the CDC certification to the civic long-term care facility certification, and really garner that level of understanding between the two?
So I know that CMS historically, they have tried to be cautious in terms of specifying a specific brand or a specific training. And typically in their regulations, they will specify topics. So for example, for the specialized training in infection control, they'll specify certain topics that have to be included in the training to qualify for specialized training in infection control. So I'm not sure in terms of specifying the CBIC certification specifically, but certainly having some alignment with the competencies between the two would certainly give a little bit more oomph, so to speak, to that certification. But also there's some other certifications out there as it relates to the long-term care infection preventionist. So for example, NADANA, which is the National Association of Directors of Nursing Home Administration, they also have a certification. And also, I believe that the American Healthcare Association has certifications as it relates to infection control. So certainly something for us to be working through and working towards in terms of having standardized level of competency, again, to reinforce the expertise that is needed to be an effective and successful infection preventionist in the long-term care setting.
And just to pivot slightly, how, from your purview, how has COVID changed the IP landscape in the long-term care facility? Of course, as an infection preventionist, just, at the height of COVID, watching the news and, as I previously noted, seeing the need for, and the need for support of infection preventionists, but just to know from your perspective that there really isn't, it's very difficult to have IP support at those sites because their hands are tied and they're being pulled in multiple directions. So how has COVID changed the IP landscape within that area?
So I think COVID has brought some positive changes into the nursing homes. So for example, nursing homes definitely have a better understanding of how to correctly implement and apply transmission-based precautions. So there's definitely a lot of learning there, identifying the need for it, identifying the benefit of it. So for example, prior to the pandemic, some of the challenges that were faced for implementing precautions in the nursing home, there were questions about the signage. So oftentimes nursing homes just had a See Nurse sign and didn't have signs that specified contact precautions or droplet precautions because there was concern about HIPAA and sharing private information with others. And now we have certainly changed that understanding and is well understood that absolutely we can have signs on the door that say contact precautions and the type of PPE that needs to be worn. Also, understanding and following through with keeping residents in their rooms when they're on precautions. So there was always a challenge with kind of accepting that for a period of time, we do need to keep residents in their room for the safety of other residents in the facility in terms of preventing the spread of infection. Also, there's certainly have been improvements in understanding that for employee health, that there are times that we need to keep our staff at home. So a much greater appreciation for employee exclusion when criteria is met for that, and following through and implementing employee exclusion based on national criteria. So certainly for COVID, we did that, and then now building on that experience and recognizing and becoming more familiar with guidelines for other types of health conditions for which we need to keep our staff at home for the safety of the residents. And then lastly, I think I would mention that definitely skills as it relates to contact tracing and outbreak management, outbreak investigation. So certainly helping to develop those skills. So which has been a huge benefit, I think, for the nursing homes. So for example, now when, let's say, a scabies outbreak pops up. So now when you start say, okay, we need to do contact tracing, they know exactly what that means, they know how to do it, and then they can go and implement that. So there have definitely been some positives out of the struggles and challenges and very, very difficult times that were faced during the pandemic.
Those are some very good points that you bring up, AC. COVID was terrible, and it was all over the news with the nursing home situation because of that group living situation and how easily things can spread. With the focus now on the enhanced barrier precautions versus transmission-based precautions, how are you seeing that being implemented, and is it an improvement?
So enhanced barrier precautions is definitely a very, very hot topic this week. CMS just released their memo, I believe it's at the end of last week, indicating that enhanced barrier precautions is now a requirement. They are incorporating it under the main infection control regulation, which is F880. And as of April 1st, enhanced barrier precautions will now be implemented. So enhanced barrier precautions definitely gives the nursing home, the long-term care setting options as it relates to trying to balance preventing the spread of infections, mitigating opportunities for spreading infections in relationship to the quality of life for the residents. So basically enhanced barrier precautions is about wearing additional PPE when there's close contact with the residents. However, the resident is still permitted to come out of their room. They're permitted to participate in activities or go to the dining room. So definitely trying to balance quality of life and the resident being able to be engaged in some of the other nursing home activities outside of their room, and versus staff and what staff are doing in terms of use of personal protective equipment to try to help mitigate and prevent the spread of MDROs and other infections.
That does allow for, I think, a better balance and more direction as far as who can come out of their room and who can participate in therapy and things like that. So will you continue to use contact precautions for people who are maybe newly infected or during the time that they're on antibiotics for a current infection? And then would they transition then to the enhanced barrier precautions? Is it two different signs? I'm just trying to, visualize this in my head, how it works, how you operationalize that.
So you have questions similar to the questions being asked this week by many of the nursing homes and the long-term care facilities. So for enhanced barrier precautions, yes, it is a different sign. And yes, there are still conditions in which contact precautions need to be applied and the residents do need to stay in their room. So for example, conditions, diarrhea, acute diarrhea, C. difficile, contact precaution still needs to be applied. When there are wounds that are draining and drainage cannot be contained or the wound cannot be covered and the dressing stays dry, then those residents still need to be placed on contact precautions. And then sometimes we also have to take resident behavior into consideration. So, for example, you may have a wound that can be covered with a dressing, and the dressing could potentially stay dry and the wound could stay covered. However, if resident behavior is such that they're picking at the dressing and things like that, then we may need to make that decision to keep them on contact precautions until there's healing of that wound or until behavior can be redirected and they're not going to be picking at that dressing. So kind of going back to what are some of the other differences in long-term care, we do have to take psychosocial needs into consideration, and we also have to take behaviors into consideration when making some of those decisions as it relates to infection prevention strategies.
Yes. AC, does one of those differences also entail having to educate loved ones regarding enhanced barrier precautions and the importance in mitigating the spread of infection?
Absolutely. So anytime a resident is placed on precautions, there is education and phone calls and communication with the family members and or the resident representative. So certainly we want the family members to understand why they're being put on precautions. And then also the resident, there's education for the resident. Sometimes residents don't understand, okay, how come I can't go to play bingo today? What's different today from yesterday? So let's say they started having diarrhea. And so also having those explanations for the residents as well.
I agree. And having worked in some post-acute environments, when you're talking to the healthcare workers and they're confused, like, well, Kelly can't come out of her room because she's on contact isolation or, whatever is going on. But having a conversation about the patient and where they are in their day, like perhaps in the morning they are clear and able to communicate and follow instructions. And then, in the evening, maybe they're experiencing some sundowning or some aggressive behavior. And then at that point, they wouldn't be able to go to dinner and they would need to make that decision to keep them in the room at that time. But it does sound very challenging and, constantly assessing the patient and where they are and what they're able to participate in. So you've described some really interesting differences in the roles of the acute care setting and the long-term care setting. So how do you believe that APIC could partner to help bolster the acceptance of infection prevention in that long-term care setting?
So it would be wonderful for APIC to assist with some of the advocacy. So advocacy for recognizing infection prevention as an area of expertise, advocacy for infection prevention can make a difference in the quality of care, safety for the residents, making improvements as it relates to infection prevention. And then also there are some issues as it relates to the financial side of things. So, for example, I was doing a training a few weeks ago, and I was hearing from the nursing homes how insurance companies are going to stop paying for the safety needles. So when it comes to injection safety, so certainly in terms of looking at payer sources and helping to advocate for those payer sources to continue funding or to adopt funding for when we need supplies to help us implement best practice to be able to support that.
Absolutely. And that's absolutely integral. And that just sheds light on the IP field within this particular space, the impact of funding, because of course, from the acute care space, I at least from my experience, I'm used to having that charge of really investing towards evidence-based practice and implementing equipment, supplies, or what have you, having the resources in order to enact that evidence-based practice. So it's absolutely integral that we have that level of support for these infection preventionists. And AC, you shared a lot of gems with us, but I would like to know what message would you want listeners to walk away with?
That we need to change the culture of infection prevention in long-term care. We need it to be recognized as an area of expertise, and with that, hopefully will come the dedication of staff and time for infection preventionists to be able to implement and do the job duties that are associated with that.
So AC, before we let you go, you had mentioned how infection prevention becomes a role for other people within the facility, whether it's the director of nursing or perhaps a wound care professional. So have you seen a recipe for the successful implementation of an infection prevention program? And how does that look?
So thankfully, yes, we have some great examples of some successful programs out there. So for example, there is a corporation that I am aware of that has made the commitment to have an infection preventionist, a dedicated infection preventionist in all of their facilities. And so having basically what it takes is that leadership support and that commitment from leadership to have an IP, for the IP to have the time to do the job, leads to success. And so we definitely have seen where we have one large corporation that's done that, and we also have some other smaller facilities that have made that commitment, and it makes a huge difference.
Yes, thank you, AC. I learned so much about IP within the long-term care space. I know that one thing that at least I learned is that there's the necessity to change the culture surrounding infection prevention within the long-term care space. There's definitely the need to have dedicated IPs at the site to really, allow for them to hone into this profession and to become educated and allow for, continuing education and certification. So, AC, I thank you for your time.
Thank you so much for having me.
Thanks, Stacey. It was a pleasure learning more about the long-term care setting today, and thank you for helping us raise awareness around infection prevention in long-term care.
Thanks for listening to APIC's 5-Second Rule Show. We want to hear from you. Visit us at www.5secondruleshow.org. That's with the number 5, where you can contribute to the conversation. Make sure you subscribe and rate us wherever you listen to your podcasts. We're so appreciative of the hard work each of you do every day to make a safer world through infection prevention. Remember, IP stands for Important Person. You are awesome. Stay safe, and we'll see you next time.